All right. So, good morning, everyone, and welcome to our weekly orthopedic surgery grand rounds. So, today I have the pleasure of introducing Dr. Catherine Woolley. Dr. Woolley is one of our fourth-year residents. She is originally from Colorado. She went to undergrad at UC, majored in kinesiology, and then spent some time as a snowboard instructor and in some other roles before eventually going to medical school at Quinnipiac University, the Frank Netter School of Medicine. There, she started to develop an interest in orthopedic surgery, and then we were fortunate to have her match with us here at UCSF. She's done a great job as a resident. She's been involved in a number of different research areas, one of which she'll talk to us today. She was recognized for her research as the first place winner at Inman Abbott for a spin bias study. She's presented her research in a number of different forums. She also received funding from the Mount Zion Hospital Fund for the study that she'll speak about today on the environmental impact of short stay total shoulder arthroplasty. So Dr. Woolley is active in rock climbing, snowboarding, and then I think she's taken her interest in these outdoor activities and transferred that into a career in sports medicine. So she's currently applying for sports medicine fellowship. She'll be starting her interview soon. She also wanted me to let everyone know that she is cool. So I will include that as part of the introduction. But I asked her for what to include, and she said, just said I'm cool. But Dr. Woolley, it's been great working with you. Excited to see the results. She's put in a lot of effort on this study specifically. This involved a lot of data collection, a lot of coordination, interaction with some external groups, and should be interesting. So congrats on your work, and look forward to hearing your talk today.
Thanks for that introduction and spoiling all my secrets. Well, thank you. I'm very excited to discuss the environmental impact of short stay total shoulder arthroplasty with you all today. So it's no surprise to us that operating rooms generate a lot of waste. We've all seen the garbage bags at the end of a case. This is an artist who's lying among the waste from one of her mastectomy procedures. I thought this was a very eye-opening reminder of how many things are used and how much waste is generated from a single surgery. This is the Lady of Justice. This is an art to waste project created by our very own Doctors Wishtrack and Asturias. She's 5 feet tall, comprised of drapes, paper, and plastics, and her plaque is written in indelible ink. In part, it reads, "As doctors, we have vowed to do no harm. But what happens when avoiding harm in one arena causes it in another? Where does the balance lie?" Today, I hope to shed some light on how we can seek balance in caring for our patients and our environment. So Dr. Churches gave a great grand rounds overview on the environmental impact of the operating room a few years ago. So we'll first do a quick review on some of the topics that he touched on so that we can better understand our research. First, we will define healthcare waste and how to measure its environmental impact. Then we'll talk about outpatient versus inpatient shoulder arthroplasty. Then we'll go into our research project about the methods, the results, some recommendations and solutions. And then if there's time, what UCSF is currently doing and how we stack up. All right, so what is healthcare waste? Healthcare waste can be broadly categorized into hazardous and non-hazardous waste. Hazardous waste encompasses infectious, pathologic, sharps, chemical, pharmaceutical, cytotoxic, and radioactive waste. Non-hazardous or general waste is just waste that doesn't pose a biologic or physical hazard. About 85% of healthcare waste is this non-hazardous waste. Now, some ways we treat this waste include thermal, which can be used for all waste types, with incineration being the most widely utilized waste disposal method. Then autoclave or steam sterilization, which is much more environmentally friendly, but it's difficult to have a large-scale waste treatment. Chemical treatment involves chlorine, ozone, or enzymes to neutralize the waste. This is used for hazardous and pharmaceutical waste. And then irradiation is just a much smaller scale disposal method. Other options include recycling, which is for non-contaminated and non-clinical waste, reuse and reprocessing for medical and single-use devices, and then finally the landfill, which closely follows incineration as the second most commonly used form of waste treatment. It's unfortunately unsurprising that the US generates the most healthcare waste compared to other countries, at 8.4 to 10.7 kilograms per bed per day. Canada was the next closest, generating 8.2 kilograms per bed per day. There are other largely populated countries that have much lower waste than us. For instance, China on the high end estimated at 4 kilograms per bed per day. Hospitals are the second largest contributors to landfills and consumers of energy in our country. The US hospitals generate 4 billions of pounds of waste annually, or 660 tons a day. 70% of healthcare waste is generated from the operating room and labor and delivery. The image on the left shows the amount of waste from one arthroscopic FAI procedure, which has been found to generate 9.4 kilograms of waste per case. And the image on the right shows the waste from one carpal tunnel surgery. Other studies have found that total knees generate 17 kilograms per case and total hips 14 kilograms per case. Most studies have looked specifically at the operating room waste, and there's not as much discussion on the associated inpatient stay. It's important to note that not all waste is solid waste. In 2013, the US healthcare system generated 655 million metric tons of CO2 equivalents, or 10% of the nation's greenhouse gas emissions. This was enough to power 85 million homes for a year and would require over 200 million tons of waste to be recycled instead of landfilled to offset. If the US healthcare sector was a country, it would rank 13th in the world for greenhouse gas emissions. And the pollution from the US healthcare sector led to a loss of 388,000 disability-adjusted life years. All right, so how do we measure this environmental impact? A life cycle analysis, or an LCA, is the gold standard. This is a process that measures the environmental impacts of a process, product, or service using a cradle-to-grave approach. This consists of analyzing everything, from the raw material extraction to the manufacturing and processing, then the transportation, usage and retail, and waste disposal. It provides the groundwork for sustainable strategy, gives us insight into resource use, human health, and ecologic consequences, and has already been used across other specialties of medicine and hospital processes. Its output is measured in CO2 equivalents, which is a metric used to quantify the global warming potential. I will use conversions to more commonly used metrics throughout the presentation as well to make things more understandable. This can be a very detailed and very long process because you are trying to capture every area of energy consumption in a case. Here's an example of an LCA flowchart for an ACL. They include everything from printing prescriptions and patient labels to even generating the operative report. Orthopaedics has some catching up to do, but we have made some progress. When Dr. Churches presented, we were tied for last with neurosurgery. We have since added a few publications, mostly outside of the US and in Europe, so there is some growing interest. Some examples of LCAs in orthopedic surgery include this study out of France. They performed an LCA of PS cemented total knees. They evaluated 17 total knees performed by 4 different surgeons. The analysis included implant manufacturing from raw materials to distribution, the journey made by the patients and the staff, and the surgery itself, including all disposable materials that were needed. They found that one total knee generated 190.5 kilograms of CO2 equivalents. They found that the prosthesis manufacturing contributed to 28% of the total carbon footprint, and of that, the manufacturing process was 72%, and raw materials, mainly cobalt, titanium, and chromium, contributed 20%. Travel was 27%, the surgery itself was 30%, and finally, waste management was 15% of the total impact. So in context, for a single operation, the total CO2 emissions generated was a little more than a New York to Detroit direct flight, and that doesn't include any associated inpatient stay. Now, this wouldn't be a complete discussion of the orthopedic literature if the ACL didn't get its moment in the spotlight. So there was an LCA also conducted in France. They investigated the environmental impact of different ACL reconstruction grafts. They did all their surgeries under regional or spinal, which helped decrease the use of anesthetic gases. They found that the average surgery generated 22 kilograms of CO2 equivalents, with surgery itself accounting for just under 40%. Of that, arthroscopy contributed 88%. In contrast, scrubbing and draping made up 39% of the total emissions, with draping alone equating to the emissions of about 1 gallon of gas. They found that the single-use drape set had the highest environmental impact of their entire LCA. In terms of the grafts, the gracilis tendon with IT band augmentation had the lowest carbon footprint of just 0.2 kilograms of CO2 equivalents. Using this technique as a reference, it was determined that extensor mechanism grafts had the highest carbon footprint, around 200% higher than the gracilis tendon and IT band. They believed the gracilis tendon and IT band to have the lowest impact because it only involved a single tibial fixation implant and no use of a saw. The average ACL generated slightly more emissions than a gas passenger car driving from San Francisco to Napa, taking the longer route. Another way that we can quantify the environmental impact is a waste audit. This quantifies the amount and types of waste generated by a process, product, or service, and helps determine effective waste management systems. All waste is collected, sorted, and then weighed, and then extrapolated to a CO2 footprint by its disposal method. It's less accurate than an LCA, but it's also a lot less time-consuming. Another study in France conducted waste audits to determine the average carbon footprint of a representative panel of orthopedic surgeries. 14 procedures were chosen: total hips, total knees, single-level cervical and lumbar fusions, arthroscopic shoulder and knee surgery, carpal tunnel releases, hallux valgus osteotomies, fixation of distal radius and ankle fractures, and short and long femoral nails. A total of 937 kilograms of waste was generated across 140 procedures, with 55% being infectious and 45% being household. The median per case was 5.9 kilograms per case, with the median infectious waste being 3.8 and household being 2.8. They found that knee surgeries had the heaviest waste weight, with an average of 11 kilograms per case, and that was regardless of open or arthroscopic. This was followed by shoulder arthroscopy. The least waste productive were the foot and carpal tunnel surgeries, at less than 4 kilograms of waste per case. Interestingly, as total waste increased, there was a lower proportion of infectious waste and a lot more household or generalized waste. The estimated carbon footprint, as an average, was 4.3 kilograms of CO2 equivalents, which is the equivalent greenhouse gas emissions as driving a passenger vehicle to Oakland. So now that we've established healthcare waste and its treatment and how to quantify its impact on the environment, we'll move on to our study. First, we'll look at outpatient versus inpatient total shoulder arthroplasty. So several studies have found there's no difference between outpatient and inpatient anatomic and reverse total shoulder arthroplasties in regards to readmissions, mortality, or complication rates, with historic complication rates of a total shoulder ranging from 2.8 to 9.4%. Studies have found no significant difference with complication rates ranging from 7 to 11%. Ahmed et al. Also found no difference in revision rates. Other studies have shown no difference in postoperative clinical improvements and even lower complication rates for the outpatient procedures. But the inpatients had higher rates of diabetes and BMI. Other studies that used matched cohorts found no difference when controlling for the comorbidities that prohibited outpatient surgery. Other studies have demonstrated very high satisfaction rates as well, ranging from 88 to 97%. And those patients said they would do the procedure as an outpatient again. Interestingly, the 2 patients who were not satisfied and would not do this as an outpatient again were taking narcotics preoperatively for a chronic unrelated medical condition. Of note, the patients who were taking narcotics preoperatively for shoulder arthritis discontinued its use in the postoperative period, and they were all satisfied to very satisfied with their outpatient procedure. This indicates the importance of proper patient selection when considering outpatient surgery. Outpatient total shoulders are also more cost-effective. About 39,000 total shoulders are performed every year, growing at a rate of 12.3%. The estimated total societal cost of shoulder arthroplasties is $490 million to $1.8 billion per year. A financial model was used to estimate savings. If 15,000 total shoulders were performed as an outpatient, they found that outpatient surgery saved nearly $6,000 per patient, with the year savings estimated at $82 million and a 10-year savings of $1.1 billion. Other studies have found that the inpatient stay accounts for 24% of the total cost, with the inpatient total shoulder arthroplasty being 40% more expensive than outpatient. In Texas, the inpatient cost was $53,000 more than outpatient, and even after excluding all the inpatient-specific charges, there was still a $9,000 difference. According to an insurance-based database, outpatient total shoulder resulted in $3,600 cost reduction compared to matched inpatients. So now that we've determined that outpatient total shoulder arthroplasty is both safe, effective, and more cost efficient, we can talk about who outpatient surgery is good for. Fournier et al. Performed a study to validate a patient selection algorithm for outpatient shoulder arthroplasty. This algorithm was created in conjunction with anesthesia at an ambulatory surgical center. It was used to stratify patients based on characteristics they believed to be the most important to avoid perioperative anesthetic-related complications. The decision points were based on data from prior hip and knee arthroplasty literature. Patient age and preoperative anemia were the first two decision points. So only patients that were 70 and younger were considered with a baseline hematocrit over 30. Then pulmonary conditions, so sleep apnea, morbid obesity, or BMI over 35. And then COPD. Cardiac conditions were considered next, things like CAD, hypertension, and CHF. The final decision points were a history of thromboembolic disease and the use of anticoagulation. If patients had one positive risk factor, it was considered a relative contraindication to outpatient surgery. If a cardiologist classified that risk factor as stable and low risk, and they had 2 or less stents and were not on anticoagulation, they could be included. But if they had more than 2 stents or were on anticoagulation, it was again considered a relative contraindication to outpatient surgery. Strict contraindications included more than 2 to 3 positive risk factors or having COPD on home oxygen. Also, any unstable cardiac condition or a pacemaker or ICD, or if the patient had had cardiac intervention within 6 months prior to surgery or open heart surgery. Using this algorithm, they performed 61 outpatient shoulder arthroplasties. All 61 patients discharged the same day. Their mean age was 58, with 64% being male, and the average BMI of 31. The majority were ASA2. Transient postoperative nausea without vomiting occurred in 3 patients, but that all resolved with oral Zofran. There were acute complications in 3 patients. 1 developed bleeding in PACU that resolved with compression, but later required the delayed evacuation of a hematoma. Non-surgical complications included a patient who had acute postoperative bradycardia, but that resolved and they were discharged home the same day. And 1 patient became acutely hypotensive at the start of anesthesia, and this actually caused the surgery to be aborted. That patient then underwent uncomplicated shoulder arthroplasty in the inpatient setting 1 month later with a standard 23-hour observation stay and a routine discharge. There were 4 more patients with complications in the 90-day follow-up period. 2 developed arthrofibrosis, 1 had mild anterior subluxation on follow-up radiographs, and 1 patient sustained a subscapularis rupture in a fall, but they ultimately declined further surgical intervention. All right, so now we can jump into our research study. So the purpose of this study was to assess the environmental impact of reverse and anatomic total shoulder arthroplasty using a life cycle analysis and a waste audit. Our hypothesis is that the associated inpatient stay would account for 20% of the environmental impact of total shoulder arthroplasty. Right, for our methods, first we observed and created a master list of all the items used in every phase of care for reverse and anatomic total shoulders. This included preoperative, in the operating room, in PACU, and the inpatient stay. We ended up collecting over 200 individual items. Our inclusion criteria were the patients who would have other qualified for outpatient total shoulders. Again, that's age under 70, hematocrit over 30, and no pulmonary or cardiac comorbidities, and no history of thromboembolic disease. We collected the quantities, mass, material, and disposal method for all of the items. We also collected the energy consumption for all the devices in the operating room, in the inpatient stay, and all the phases of care, the energy for the HVAC, the lighting, and the laundry. We categorized items by phase of care and then further subcategorized as well. We performed a waste audit with an LCA of the waste collected at the end of every case and at the end of the inpatient stay. The waste audit was calculated separately from the LCA because this focused on the waste, the weight of generalized waste, rather than the exact contents of the waste. And the exact contents of the waste were accounted for in the LCA using that cradle-to-grave model. The waste audit estimated emissions from the weight of waste and the associated treatment method. So here's a flow diagram of the scope of our LCA. We started with the raw material extraction, including all the composition of all the implants. We then move on to the manufacturing and processing, taking into account the natural gas and electricity used to run our buildings, as well as the manufacturing of the implants. Then transportation of all the supplies. We did not take into account the transportation of patient and staff because this was out of the scope of our study. We then move on to the usage phase. So again, that includes all of the monitoring devices in pre-op, PACU, inpatient in the OR, all operating room equipment and machines, all disposable OR materials, the inpatient sharps and landfill waste, all the reusable surgical instruments, the medications and anesthesia given in all the phases of care, the linens and the implants. And then finally, the waste disposal. All right, so we collected surgeries performed by 3 senior surgeons at UCSF between June of 2023 and March of 2024, who would have otherwise qualified for outpatient surgery based on the algorithm we outlined earlier. We found that age and COPD or sleep apnea were the most common reasons that patients didn't qualify. So we ultimately collected data from 21 cases with an average age of 62, with 11 being male and 10 being female, and an average BMI a little lower than Fournier et al.'s study at 28. We found that the average impact per patient was 148.2 kilograms of CO2 equivalents, with 2% of that coming from pre-op, 61% coming from the operating room, 27% coming from anesthesia, 1% coming from PACU, and then 9% coming from the associated inpatient stay. So in total, the average total impact was the same emissions as driving a gas passenger vehicle to Thousand Oaks, with the impact of surgery alone getting you to San Luis Obispo. So our average impact of the OR was much higher than the ACL study I mentioned earlier. They found an average of 22 kilograms of CO2 equivalents per case, but the scope of this study was much smaller. They did not include the manufacturing or transporting of goods or all of the OR equipment and machines. They also didn't include the manufacturing of medications and the packaging waste. And our impact for the OR of 90 was lower than the study of total knees, though total knees included the patient and staff travel, which we did not. If you remove the travel, the total knee average impact decreases to 140 kilograms of CO2 equivalents. In their study, surgery specifically only made up 57 kilograms of CO2 equivalents, which is much less than ours. They did not include anesthesia medications, which I think could lead to an underestimate of their total carbon footprint. Here we can see the total kilograms of CO2 equivalents by patient. We had one outlier, patient 10. This patient had about 3 times the anesthetic drug emissions from increased rocuronium use, and also they were only one of 2 patients who used nitrous oxide, which is a potent greenhouse gas. And here we can see the average environmental impact by kilograms of CO2 equivalents per patient by category. I highlighted some of the hot spots. So that includes anesthesia supplies, or the items that anesthesia uses in the operating room, excluding their medications. So that's the tubing, the airway, pulse ox, tape, blood pressure cuff, EKG leads, syringes, needles, etc. And then the anesthetic medications, which include the gases. And then finally, the pack. The pack is everything that comes in those Medline soft packs. So that's cautery, containers, cords, Mayo stand covers, light handle covers, skin markers, suction tips, towels, etc. Interestingly, the implants only contributed 4.7 kilograms of CO2 equivalents. That was less than half of PPE at 10.1. We have a lot of learners in the room, so I thought that was okay. That was actually over the energy required to run the operating room at 9.4 kilograms of CO2 equivalents. The total waste collected in the operating room was 546 kilograms, with a total emissions of 99.2 kilograms of CO2 equivalents, with the average of 26 kilograms per patient, equating to 4.8 kilograms of CO2 equivalents. The landfill made up 66% of total waste, followed by linens at 25%, recyclables at 6%, and biohazardous at 3% of the total waste. Our waste audit of the landfill and biohazardous waste had an average of 0.6 kilograms of CO2 equivalents per patient, with a total of 11.9 kilograms of CO2 equivalents for the study. Our LCA of the linens demonstrated an average of 4.2 kilograms of CO2 per patient, with a total of 87.3. So the average OR waste per patient was the same as driving to Oakland, with the total from our study of all waste emissions from the operating room equating to driving to Mammoth. Recall that in comparison, the waste audit of the representative panel of orthopedic surgeries found an average of 5.9 kilograms per case, which is much less than ours, with a median of 3.8 coming from infectious or biohazardous waste and 2.8 coming from household waste. Their estimated footprint was interestingly close to ours at 4.3 kilograms of CO2 equivalents per case. So it seems that we generate much more waste per case, but less of that is biohazardous, and much more of that is general waste. So the difference in this ratio of infectious to non-infectious waste has ultimately led to us having a similar carbon footprint because we're decreasing what has to be treated thermally. Here are two photos of two different cases of the amount of waste generated after 2 total shoulders at Mount Zion. As we can see, the kilograms really start to pile up here. The total waste for the inpatients was 237.9 kilograms, and that generated 156.7 kilograms of CO2 equivalents, with the average patient generating 11.3 kilograms in total, and that equates to 7.5 kilograms of CO2 equivalents. Linens made up the vast majority at 65% of the waste, followed by landfill at 33%, and lastly, sharps at 2%. The LCA of the linens found that the average emissions amounted to 4.7 kilograms of CO2 per patient, or 99.4 kilograms of CO2 equivalents in total. The average inpatient waste per patient was the same as driving to Foster City, and the total for our study was the same as driving to and from Tahoe, which makes me feel a little bad about my ski trips, but I carpool. All right, so what are some things we can do in the operating room? Sala et al. Did a review looking at the current evidence and recommendations of changes that we can make to decrease our environmental impact in orthopedic surgery. There's not a lot of data out there, so there was only one grade A evidence, and that was to use waterless scrub. Then there's some grade B evidence of things I think are pretty intuitive: expanding telehealth and the judicious use of air travel, and then minimizing the use of inhaled anesthetics and minimizing implants and instruments. Then we have some grade C evidence for exploring satellite clinics, exploring powered down initiatives, transitioning to reusable materials, and minimizing red bag waste because that needs to be thermally treated. And then there's insufficient evidence, but I think this makes intuitive sense, to create a group to make change at the hospital level. I want to spend a little more time talking about the anesthetic gases. So anesthetic gases, less than 5% are metabolized by the patient, and the vast majority is vented back into the atmosphere as a greenhouse gas. Anesthetic gases generate 50% of the greenhouse gases of surgery and 5% of the hospital's carbon footprint. Every commonly used anesthetic gas is a potent greenhouse gas. Their carbon footprint can be measured using a global warming potential, which is a comparative scale that describes the heat trapping capacity of a substance compared with the equivalent amount of CO2. So the global warming potential 100 means the GWP over 100 years of CO2 is 1. So in reference, sevoflurane, GWP 100 is 130. Using it for an hour is the same as driving 4 miles. Isoflurane, the GWP 100 is 510. Using that for an hour is the same as driving 8 miles. Then there's desflurane. The GWP 100 is 2,540. Using that for just an hour is the same as driving 190 miles. Nitrous oxide, as you saw the outlier in our patient, the GWP 100 is 265, but it lasts in our atmosphere 114 years. And so using that for an hour is the same as driving 60 miles. So I think how we can see just a little bit of nitrous oxide really created a big bump in that patient's emissions. Some institutions have started acting on these findings. The Carolinas Medical Center implemented a Green Operating Room Committee in 2008. As part of their efforts, they focused on reducing operating room waste, which resulted in the diversion of 6.5 tons of medical waste over 5 years. They specifically focused on decreasing their biohazardous waste, which costs 10 times as much as general waste to dispose of, and again requires incineration at their institution. They also started a power down initiative to turn off all anesthesia and OR lights and equipment when not in use. That resulted in the savings of $33,000 and 234 metric tons of CO2 emissions per year. They also started recycling all single-use devices, decreasing their solid waste production by over 12,000 pounds. They switched from disposable OR foam padding and used reusable gel pads, saving $50,000 a year. Over 500 pounds of discarded batteries were salvaged from the operating room and were donated or redistributed, leading to $9,000 of annual savings. And they switched from soap to an alcohol-based waterless scrub, saving 2.7 million liters of water every year. With these changes, they saved over $158,000 per year. So as we saw in our study, the surgical packs contributed heavily to the carbon footprint of the procedure. Bravo et al. Evaluated opened but unused single-use OR supplies for hand surgery at an ambulatory surgical center. So again, they're defining waste differently from us. Our waste was everything in the garbage bags at the end of the case. These are things that were specifically opened, not even used, and then thrown away. They found that the most commonly wasted items were Ratex, surgical blades, and stockinettes. They found that 22.6% of the custom pack was opened, unused, and ultimately wasted. The highest carbon footprint of the wasted items came from the bipolar, basins, drapes, and stockinettes. Over 85 cases, their waste amounted to $2,193 and 441 kilograms of CO2. That's the same emissions as driving a passenger vehicle from here to Vail. Van Denmark et al. Began a lean and green project at an outpatient hand surgery center in South Dakota at the Sanford School of Medicine. They used field sterility, which we can see an example of on the far right. This eliminates disposable gowns. It just uses sterile gloves with drapes and wide-awake local anesthesia with no tourniquet, as well as smaller surgical packs and less instruments. This project led to an average of 5 pounds of less waste per case and saving just over $10 per case. Over 2 years, this accumulated to 2.8 tons of less waste and over $13,000 of cost savings. The figure on the left is an example of a standard setup for a carpal tunnel, and on the right is an example of their lean and green setup. They found no change in infection rate and had high satisfaction rates. Patients even thought the experience was better than going to the dentist and would recommend this to a friend or family member. They estimated that if all the active hand surgeons in the US participated in this lean and green challenge and did just 100 green surgeries a year, then they would save $2.13 million and decrease 560 tons of waste in a year. And here's a photo of a back table for a standard total shoulder at Mount Zion. We can see there's a lot more on our table compared to hand surgery, and especially the lean and green setup. So I think there's more room for improvement here. Another way that we can eliminate waste is with the extra packaging or wraps. This group out of the Netherlands performed an LCA comparing the sterile blue wrap or rigid sterilization containers. They even investigated a closed loop cycle, meaning recycling the blue wraps instead of going straight to the incinerator. Either way, the rigid sterilization container was still 84% less of an environmental impact than the blue wraps. So for things we can do on the inpatient side, first off is food, which is something that we did not specifically look at in our study, but we've all eaten hospital food, so I think it's not surprising that about half of it gets wasted, and that amounts to 540 grams per patient per day. Other changes can be made on the staff level. A study in Melbourne found that after waste education and increased signage, their inpatient sharps waste significantly decreased. A study of an ICU in Brazil installed separate waste containers for non-recyclables and chemical waste and educated their staff on proper recycling. They reduced their solid waste generation from almost 14 kilograms per patient a day down to 8. Their main finding was that staff didn't know they had to remove labels for proper recycling. This group out of Switzerland performed LCAs of 33 acute care hospitals in Switzerland. Their scope included building energy usage, waste and wastewater, catering, textiles, housekeeping, paper, pharmaceuticals, and equipment. They reported units in a functional unit, which equates to the healthcare services provided by one average full-time staff member over the course of 1 year. This allowed them to compare between institutions with different levels of care and different levels of outpatient and inpatient services. Prior studies have found that outpatient services typically contribute 1/3 of the emissions compared to inpatient. So in this study, the total emissions per hospital were divided by the healthcare services provided by that hospital's staff. So an institution with multiple CT and MRI scanners or more outpatient services could be differentiated. They found that the average hospital generated 3.2 tons of CO2 equivalents per functional unit. This is the same emissions as driving a gas passenger vehicle to and from New York twice. This shows their breakdown of the carbon footprint by category. They found that the highest contributions of the carbon footprint of running a hospital was heating at 26%, followed by catering at 17%, building infrastructure at 15%, and pharmaceuticals at 12%. In our study, the energy included the HVAC, equated to 9.5%. Though we don't live in a snowy environment like Switzerland, and they had one outlier that was up near the mountains, and we only looked at one single surgery, not the hospital as a whole. Our pharmaceuticals were also much higher at 40%. Again, we focused on surgery, and I think that makes it higher with the use of anesthetic gases and more pharmaceuticals being given in a shorter period of time. For the food, their study found that 2/3 of the contributions of the carbon emissions were from milk products and fish, which we'll come back to in a few slides. All right, so in summary, things we can do in the operating room to lower the impact of our surgeries is to use waterless scrub, minimize or alter the use of inhaled anesthetics, minimize unused surgical items, and invest in lean and green surgical packs. We can also minimize or recycle single-use devices. For the inpatient stay, we can simply consider outpatient surgery for appropriate patients. We can invest in energy-efficient buildings. We can limit excessive linens. We can decrease the portion sizes of hospital food or invest in sustainable food. We can use appropriate recycling and disposal methods and decrease our packaging. Some things that I've personally been paying closer to attention to after preparing for this talk is proper waste disposal. I think that's one of the easiest things that we can make small changes on every day that can make a pretty large impact. We should keep in mind that all things placed in the black or general trash containers are not sorted and are just added straight to the landfill. So think carefully if what we've thrown away could have been recycled or composted. In the operating room, remember that everything we throw away in the red bags should be biohazardous waste and should have the potential to spread blood-borne pathogens. In gross terms, if blood could drip off, flake off, or be squeezed out during handling, it belongs in the red bag. Everything in those bags has to undergo thermal treatment prior to the landfill. So it may be convenient to just throw something away in the closest receptacle, but those small decisions can have a big effect on the carbon footprint of our operations. Proper waste disposal for special materials like batteries is also critical because the electronics contain toxic chemicals, and if simply thrown away in the landfill, can lead to environmental contamination with lead, cadmium, mercury, and lithium all leaking out into the soil and groundwater. I didn't realize that all our pulse lavages come with a bunch of batteries in them, and usually we just toss that into the trash at the end of a case. But really, we should be taking them out and salvaging them, or take them home and use them in your smoke detectors. All right, now that we're all a little depressed about the impacts we have on our environment, I thought we'd share a little bit about how UCSF is doing and some different initiatives that we can participate in to help. UCSF is actually already enacting on a lot of the findings from previously mentioned studies. You may recognize these signs. UCSF has taken great measures to make compost, trash, and recycling signs easily understandable, and that these containers are easily accessible for staff and patients near patient rooms, but also in common spaces and near the restrooms. There's also an online waste sustainability training course offered by UCSF, but hopefully we won't need that after this talk. Furthermore, UCSF purchases more sustainable and plant-based food. Recall that the prior LCA of hospitals in Switzerland found that milk and fish was the vast majority of their food-related emissions. So by investing in plant-based food and Meatless Monday, UCSF is limiting its environmental impact. UCSF has also reduced greenhouse gas emissions by 26% since 2015, with a goal of carbon neutrality by 2025. One way they've done that is eliminating the use of desflurane, which we talked about is the most potent greenhouse gas producing inhaled anesthetic. We have also installed a solar array on the Gateway building in Mission Bay, which supplies 10% of the energy to that building. All electricity that UCSF Health purchases from the grid is also 100% carbon-free. And the new outpatient surgery center here in Mission Bay is all electric, zero carbon. UCSF also has a goal of transitioning to a 50% electric vehicle fleet by 2025. We can see that in 2019, we started using more reusable sterilization containers, but that's remained pretty stagnant since then at just over half. I think we have a lot of room for improvement there to improve our carbon footprint. Also in 2021, we can see we started reviewing our OR packs for waste. Again, I think the findings of our study show that there's some more room for improvement for that as well. UCSF has a goal to divert 50% of waste by 2025 and decrease waste per patient per day to 25 pounds by 2025. That's actually the amount of waste per patient we found on the inpatient side of our study. They have a further goal to decrease to 20 pounds per patient a day by 2030. On the right, we can see the total amount of waste per patient per day, and our total shoulders are doing better than the average. The average is 31.2. We can see the waste diversion on the left. In 2023, we were at 35.4%, and we can easily see the impact that the COVID pandemic had with the generation of a lot more infectious waste that could not be diverted when we dipped down to 17.6%. Prior waste audits performed at UCSF found that on average, a case produces 28 to 55 pounds of landfill waste per case. Our findings were just under that at 22 pounds. From 2021 to 2023, we've increased our recycling nearly 1 pound per person per day and decreased our medical waste nearly 2 pounds per person per day. UCSF also diverts special materials and diverted 4 tons of batteries, 68 tons of electronics waste, 2 tons of toner cartridges, and 8 tons of fluorescent light bulbs. They host electronics recycling events, and you can even put in a work order to facility services to pick up your electronics waste if you can't make it to an event. Additionally, UCSF has a medical supply donations program, and in 2022, donated nearly 20,000 pounds of medical supplies. So where does all of our waste go? Our compost is transformed over 60 days at a facility in Vacaville, and then it becomes nutrient-rich compost for vineyards and farms throughout California. Our trash is taken to a landfill in Livermore, California. And if you're more interested, there are tours of Recology, which is the San Francisco waste hauler, and they're offered every month. Our biohazardous waste is taken off-site and actually steam sterilized and then taken to a landfill. Our pharmaceuticals are incinerated, and our linens are washed and reused in Gilroy. So again, I want to end on this Lady of Justice with her scales balancing the patients we care for and the impact that our care can have on the environment and our public health as a whole. It's a difficult balance to find, but luckily we work in an institution that supports environmentally friendly efforts and is taking large steps towards it, though I think we still have a long way to go. So I urge us all to make environmentally conscious decisions, and those that have the power to enact change to consider the changes that we've talked about. And here are our references. And I want to give a really huge thank you to Kai, Kian, Abu, and Melanie and Dr. Eckelman, our LCA analysts, and Dr. Gandhi and Dr. Lansdowne. This project was a huge amount of effort and would have been impossible without them. And I hope that everyone here today can get the chance to get outside and enjoy some of the beautiful outdoor environments we have in the Bay Area. Thanks.
Future for some of the behavior changes that are happening at a socially aware institution like UCSF can be generalized more broadly? And is that going to require something like monetizing carbon credits? And does that require an infrastructure that doesn't currently exist in terms of auditing and et cetera? So what are people talking about in terms of more generalized sustainable change?
Yeah, that's a very good question. I think UCSF is pretty progressive. I don't know if they would monetize, but I do know they are investing in that carbon-free energy. So I think that the infrastructure exists. It's just a matter of getting the, encouragement and people wanting to actually invest in that. I don't know if UCSF is specifically looking at monetizing that, though. But I do know as they build new buildings, like the new Parnassus building, they are trying to make everything carbon-free or carbon neutral and make everything LEED certified. So they are motivated to do so.
Dr. Luke.
Mhm. Yeah, absolutely. There's nothing mandatory yet, so you won't like find it on the packaging. But I would not be surprised if something like that happens in the future. When you go grocery shopping now, you'll notice that a lot of the like granola bars will say this has 2 kilograms of CO2 equivalents, or like if you buy shoes from Asics per se, they actually say that in your order as well. So other things are starting to report this. I think in healthcare, people aren't so much motivated to because it's going to be pretty high. In terms of it being mandated, there's no discussion of that so far. If you are interested in the environmental impact, the best way to, unfortunately, it's just such a complicated process because for the pharmaceuticals, they have to go all the way back to sourcing everything, manufacturing it, the packaging, and oftentimes it bounces around between different companies. And so really the best way to get an accurate understanding is unfortunately an LCA, which is a huge amount of effort. I do hope that as we go through and people get more interested in the environment and understand its importance, I hope there is some regulation behind this. I do think it would require a lot of policy change because this is a huge amount of effort to report these findings. Also, very difficult to keep everything standardized. As you could see from our different LCAs, we kind of all found wildly different results because there's so many different scopes. Some people could say this is just the environmental impact of the liquid in this vial, and they didn't include making the vial. Or this is the impact of this medication, but we didn't include transporting it to you, which is a ton. So I do think there are some challenges there. And if you are personally interested, you can try looking up other studies that have used similar products. Unfortunately, there's not a ton in orthopedics. Yeah.
Matt.
Is there any discussion about the carbon footprint of labor? So if you look at the cost of delivering care, over 70% of it is labor for orthopedic surgery. You're going to think about expensive implants or supplies. So the reality is when we look at cost savings, just for cost savings standpoint, a lot of it's improving the efficiency of labor and reducing the amount of time things take. So is there any philosophical discussion of, is there a carbon footprint associated with labor?
Yeah, I think especially for surgery with the use of the gases, I think the longer the surgery is, we can see that really compounds. And we just finished up our data collections. And one of the things we collected was the length of the surgery itself. So we hope to do a secondary analysis and try to compare that. And then again, as you can imagine, every day in the hospital accumulates more waste. So obviously, if you're able to discharge people more streamlined, it would cut down on the carbon emissions. But I think the most impactful thing is going to be cutting down on operating room time, or maybe other regional anesthetics or things we can do to just cut down more on the anesthetic gases, as that's one of the biggest impacts.
I think we had a hand up on Zoom from Dr. Immerman. You want to?
Yeah. Thanks. I think some of it was already asked. I was just thinking and to make a comment about how I feel like the role of government and regulators has to increase in this field significantly. Like as an example, when we were setting up wide awake surgery at the OI, we wanted to use fewer things and smaller packs. And, we talked about briefly like field sterility, but there's concern about, what do our regulators think about infection risk? How do we manage that? The cost of surgical packs. Actually getting a smaller surgical pack would require building a custom pack, which would be much more expensive than what we currently use. And because, we use the same pack for many operations, and the carpal tunnels and triggers are like a small part of what we do, it was financially not incentivized. So once I think, carbon credits, all those things, if they become financially important and allowed, we can have field sterility, no regular bats concern about us doing surgery that way, then it becomes easier. So I think it's been brought up already. So.
Yeah, I think surgery is particularly tricky because we need to prioritize changes that don't compromise the safety of our patients. And we have a lot of regulatory requirements for infection control. There's also kind of like that other study I showed from the Carolinas Medical Center. There's high initial costs for sustainable products, but then ultimately it can lead to cost savings and savings for the environment. So we do need buy-in from the hospital, from our political leaders. I mean, this is something that needs to be a change from all around.
Dr. Kwong.
Congrats, Kat, on a great talk and really interesting project and thought-provoking one too. I want to ask if you thought there's any role for sort of bringing this to the patients and helping them understand the carbon footprint of their hospital stays. And because, for example, airlines, they sort of market themselves to say, we do this, that, and the other to decrease our carbon footprint. Do you think there's a role for educating patients about the impact of their hospital stays and hospital care as well?
Yeah, absolutely. I think, like I said, I think this requires buy-in from everyone, and that includes the patients. I think that if we start sharing with patients the changes that we've made, particularly amongst our building infrastructure, the food. I know some people, like at some hospitals, they don't like Meatless Monday, but I don't think they realize how important it is for our environment. And I think one of the biggest things we found, one patient used like 26 pounds of linens for a 23-hour stay. And all of that has to get trucked out to Gilroy and cleaned and brought back. I'm not sure they needed 26 pounds of linens, but I think if we just shared with them that, this isn't a thing you can just keep taking and taking and taking and never have to give back to the environment. I don't think a lot of patients understand the impacts, especially in a hospital environment. I think it almost has almost like a hotel feel to it, because things just get picked up and cleaned up for you and you never really see it. So I think it would be important if we can share this with our patients. But it's hard because we have to balance their care and their comfort and make sure that they're warm enough with all their linens. But yeah, I think this would be something we could share with our patients.
Yeah, that was really amazing. Great job. You should feel so proud of all the work you went into that, and I hope it gets published widely. My question for you is operating at all the different hospitals, and I also go a lot of places, and so I see that each OR is a little bit different. And my impression is that the VA and the general maybe are running a little bit leaner in the OR with their sets and different trays. And the general, especially, I think they have more compostable items on the back table. And I was just wondering if you had any more information and if you have any data or knowledge if we at UCSF can take some best practices from the other hospitals if they're doing a better job in the OR.
Yeah, that's actually a really good question. I mostly focused on UCSF. I didn't have access to the county and the VA and what exactly their regulatory practices are. Again, I think that kind of highlights the big challenge is making change at that hospital level. Like we saw Carolinas Medical Center was able to do certain things, and that required buy-in from all of their services and everyone there. And at UCSF, we're making some change, but we all are still affiliated with other hospitals. So I think if we're able to kind of share some of the things we're doing with each other, that could help make those changes. But again, we're facing a lot of infection control regulations and things that are, at least above my pay grade. So.
Any other comments, questions? We're approaching 8 o'clock. So Dr. Woolley, thank you so much. This was really excellent, and congratulations on your work.